I will move on to the next talk, which is on the discussion of T-cell lymphoma management. The topic is, what are the most promising new approach and agents for T-cell lymphoma? I think it's a very grand question, and there's really no easy answer. Instead, I like to provide a review to summarize what are the unmet needs, what have we done to address those issues, where are we heading, and what's our great expectations for T-cell lymphoma management. So as you know, T-cell lymphoma is relatively uncommon and also biologically heterogeneous. It presents as clinical challenges for patients and for provider as well. And according to the 2008 WHO classifications, the T-cell lymphoma represent about 10 to 15% all non-Hodgkin lymphoma that we see in Western countries, with most common subtypes represented by PTCL, NOS, angioimmunoblastic T-cell lymphoma, and ALCL. In contrast to the B-cell non-Hodgkin's lymphoma, where the conventional therapy is based upon using CHOP-like therapy, outcomes remains to be very suboptimal. With the exception of ALCL, particularly those ALK-positive subtypes, other PTCL subtypes such as AITL or PTCL-NOS generally has poor long-term outcome with 5-year survival around 30%, which is certainly unmet needs for patients with this disease. So the new WHO classification in 2016 began to incorporate additional biological data based on the gene expression profile and deep sequencing data, starting to provide provisional diagnosis based on cell of origin. For example, there's a new entity called nodal PTCL with follicular helper T-cell phenotype. Essentially addresses the recurrent genetic mutations with epigenetic modifier, where those PTCLs are more closely resembling angioimmunoblastic T-cell lymphoma, in contrast to the regular PTCL-NOS. It's a small step, but very meaningful step in terms of providing a better diagnosis, prognostic criterion that are biology-driven, and hopefully that would be impacting our clinical decision-making and also future clinical trials in that fashion. So the unmet need in managing PTCL, one is to improve the efficacy of initial therapy, and the other, obviously, is to address relapse refractory disease. The approach to improve efficacy in the frontline setting has been incremental, adding to the CHOP-like backbone. For example, adding biological agents, as listed here, by introduce upfront autologous stem cell transplant for patients with chemotherapy-sensitive disease, and as well as start to moving more mature novel therapies into the frontline setting, incorporating with either chemotherapy backbone or novel therapy by itself. So I'll touch upon two aspects of adding to the conventional backbone. One of them is to adding etoposide. As you all know, the efficacy of CHOP-like regimen would give you about a 60 to 80% overall response rate, and half of them are CR in previously untreated T-cell lymphoma patients. However, durable remission is rare, so generally speaking, long-term responders are usually in about 20-30 range. The benefit of etoposide adding to CHOP is extrapolated from retrospective analysis. Notably, one of the study was a German retrospective study looking at 7 trials put together and evaluating those previously treated with either CHOP-like regimen. And that particular study showed that adding etoposide appears to improve event-free survival, particularly in patients that's younger than 60 and with normal LDH, and that particular benefit seems to be more so in ALK-positive ALCL patient. A similar conclusion was extrapolated from the Swedish population cohort study, where in a subpopulation of 250 plus patients under age of 70, PFS also appears to be improved with addition of etoposide to the CHOP-like regimen. The role of autologous stem cell transplant as consolidation following initial induction has been studied in numerous studies, and a number of them were prospective phase 2 studies represented by the German study and also the Nordic lymphoma group study, which seems to be the largest series to date. There are also a number of retrospective multi-center studies looking at selected group of patients received transplant. So the prospective study using autologous stem cell transplant, essentially give a progression-free survival 3 to 5 year in the range of close to 40%. And overall survival above 50%. And that is to contrast with a more selective patient in a retrospective review fashion where 3-year progression-free survival was around 60 and 3-year overall survival was reported about 70. There's really no randomized phase 3 type of study data available. The closest that we come would be extrapolated from the population study of the Swedish registry, where in those 250 patients under 70, there appears to be a survival advantage for those who moved on to autologous stem cell transplant consolidation compared with those did not receive transplant. And so therefore, we generally encourage patients to be evaluated for autologous stem cell transplant, especially those with non-ALCL subtype advanced stage disease and chemosensitive following induction therapy. So most of the impact of improving PTCL treatment would come from novel therapy clinical development, and I'll address them in 2 fashions. One is to evaluate or review the novel agents development in the relapsed refractory setting, and also current approaches of moving some of them into the frontline settings. So the first group are agents that are received treatment indications. There are 4 of them in US, namely the antifolate, pralotrexate, the antibody drug conjugate, anti-CD30, brentuximab vedotin, and 2 HDAC inhibitors, romidepsin and belinostat. There are 2 additional agents outside US receiving treatment indications, including the anti-CCR4, mogamulizumab in Japan, and chetamide, which is an oral HDAC inhibitor in China. A very brief review of those single agent data. Pralotrexate, when provided as a weekly infusion, 6 weeks out of 7 weeks at 30 milligram per meter square doses, gives an overall survival of 29%, including CR about 10%. The median duration of response was about 10 months, and common AEs, adverse events, included mucositis and cytopenias, which can be managed by supportive care and also dose adjustment. Numerous studies have been conducted with pralotrexate as combination, and pralotrexate has also been evaluated in combination with chemotherapy, which we will review in a short while. The antibody drug conjugate, brentuximab, delivers antimicrobial toxins to CD30 positive target cells as a single agent in systemic ALCL. that are expressing CD30, the overall response rate was at a very impressive 86% with 57% CR, and it's delivered at 1.8 milligram per kilogram and every 21 days as a treatment cycle for a maximum 16 cycles. The common side effects including neuropathy, which are dose-dependent and can be managed with supportive care, and cytopenias are very moderate. In experimental settings, single-dose brentuximab has been evaluated for patients with CD30 positive T-cell lymphoma in a phase 2 study that recruited primarily AITL and PTCL-NOS patient. The single-agent brentuximab produced an overall response rate of 41%, including CRs. And the patient with AITL subtype seems to be more sensitive. From this particular study, a combination of brentuximab and chemotherapy are currently in development for frontline setting, which we will discuss in a little bit. The HDAC inhibitors, so far we have 2 agents. One is romidepsin, which is more selective class 1 HDAC inhibitor. It's provided as a weekly infusion, 3 out of 4 weeks. The belinostat is a newer agent. It's provided as a daily infusion for 5 days, and each treatment is 3 weeks. So the 2 compounds seems to have very similar efficacy data in terms of overall survival at around 25 to 26% with a CR portion, and romidepsin has longer follow-up data with a duration of response up to 28 months, and that correlates our own clinical experience where a fraction of patients appears to be able to tolerate this agent and maintain their response at a prolonged exposure. And belinostat, on the other hand, seems to have less myelosuppression, and currently it is being evaluated in combination with chemotherapy in the frontline settings. So example of combining biologics in the relapse settings, one of them is given here. For example, romidepsin has been studied in combination with lenalidomide, another agent which has shown biological activity in T-cell lymphoma. In a multi-center phase 1-2 study where romidepsin given weekly, 3 weeks out of 4, plus lenalidomide daily dose, 21 days out of 28 dose, was provided to patients with T-cell lymphoma. A total of 21 subjects was enrolled, and the overall response rate was recorded at 53% with a CR portion. Long-term follow-up of this cohort, the data is awaited, but the activity is very encouraging, and this has become a base for a frontline treatment design, which we will discuss in a short while. So the second group of novel agents are listed here, and by no means this is comprehensive. Those are essentially summarizing data from biological agents that having published safety and efficacy data, as well as extrapolating from newer agents which are studied in the mixed histology phase 1b and 2 settings. Examples included the anti-CCR4 antibody, which has a heightened ADCC function. In addition to its efficacy in ATLL, in PTCL, it appears to have activity in the range of about 30 to 40%, including CR rate. And this particular agent is also being developed in CTCL. Elucitab is a oral aurora kinase A inhibitor. When provided as a daily dose for 5 days, every 3 weeks dosing regimen, it produces about 24% of overall survival, overall response rate with a small portion of CR. Based on this phase 2 data, single-agent elicitab has been developed in a phase 3 study comparing investigators' choices of either romidepsin, pralotrexate, or gemcitabine. We're currently awaiting the maturation of the study outcome. Duvelisib is another PI3 kinase selective for PI3 kinase isoform delta and gamma. And in a phase 1b study, the single-agent duvelisib produces about 42% response rate, including a CR portion. And currently, combination of this compound with other biological agents are in development. And the subsequent compounds listed on this particular tables are essentially reagents with interesting potential clinical signals. For example, immune checkpoint inhibitor nivolumab was studied for patients with lymphoma, including 5 patients with PTCL. And in that particular study, the response rate was 40%. However, there was no CR. And additional clinical trials with checkpoint inhibitor, including nivolumab and pembrolizumab, as either single agent or in combination with other biological agents, is currently ongoing. And it would be very interesting to see if they have any durable clinical benefit in patients with T-cell lymphoma. Selinexor is a selective inhibitor of nuclear export. And in a phase 1 study with mixed lymphoma histology, 3 patients with PTCL was included. And we have observed some clinical activity, including CRs. So it is conceivable that this particular compound can be used in combination with chemotherapy to sensitize response rate. And a note of interest on crizotinib, which is ALK kinase inhibitor approved for small cell lung cancer. In a compassionate small study series, durable response up to 60% was observed in patients with ALK-positive ALCL. Based on those small data sets, currently the Children's Oncology Group is conducting a study combining crizotinib with chemotherapy and comparing that with brentuximab plus chemotherapy combination. So very lastly, we would be reviewing the incorporation of novel agents into the frontline setting. Majority of the case would be in combination with chemotherapy. A phase 2 study was conducted by the T-cell consortium led by University of Nebraska in collaboration with NCI. In this particular study, which has been completed and reported, the pralotrexate was combined with CEOP, which essentially replaced adriamycin with etoposide for chemo combination in a sequential fashion where CEOP provided, followed by pralotrexate weekly for 3-week dosing. If 33 patients was evaluated for this particular treatment, and overall response rate of 70% was reported with a very respectable CR rate. Treatment-related side effect was substantial with cytopenias, infection. About 45% patients subsequently move on to autologous stem cell transplant. The final outcome revealed that 2-year progression-free survival was around 30%, and 2-year overall survival was about 60%. The authors of this particular study concluded that it does not appear to be more superior compared with historical control, which again emphasizes the challenges that we're facing in providing improvement in T-cell lymphoma treatment. Additional phase 3 studies are really currently in recruitment, and results are eagerly awaited. Those included the combination of brentuximab plus chemo backbone, and HDAC inhibitors plus chemotherapy. So very, very quickly, brentuximab vedotin has been combined with CHOP-like chemo in phase 1 portion. The study was conducted either in sequential fashion of brentuximab followed by chemo versus concurrent brentuximab plus CHOP without vincristine. The concurrent regimen seems to be more superior with a 100% response rate and very high CR rate. And based on that, a current phase 3 study known as the Echelon 2 study is in full swing, in fact, very nearing its enrollment target to compare conventional CHOP therapy to brentuximab plus CHP as induction chemotherapy. The design is real life and rather flexible in that patient can subsequently moving on to autologous stem cell transplant based on the physician's discretion. So progression-free survival as primary endpoint and response rate from that phase 3 study are eagerly awaited. The HDAC inhibitor romidepsin has been studied also in combination with CHOP. Those were conducted by the European study group. In the phase 1b and 2 portion of the study, the maximal determined tolerable rate doses was revealed at 12 milligram per meter square, given weekly for 2 doses on day 1 and day 8 to combine with CHOP 21 backbone. And this particular study showed also fairly substantial side effects with cytopenias, infections, and also constitutional decline. However, the overall response rate and CR rate at 51% and 18-month progression-free survival, 57% was solid enough to move this particular design into the phase 3 portion where romidepsin plus CHOP at 12 milligram per meter square dosing for romidepsin will be compared with CHOP alone, and that study is in active accruement at this point. Another way of evaluating adding novel agents such as romidepsin is to see how that's going to augment maintenance portion following induction chemotherapy and autologous stem cell transplant. Currently, we have a multi-center phase 2 study ongoing for that particular design, where patient would be induced with CHOP-like regimen, moving on to autologous stem cell transplant, and subsequently getting romidepsin every other week as maintenance for as long as tolerated and with clinical benefit. Again, the primary endpoint is progression-free survival. As mentioned before, the phase 2 data on the relapse setting with romidepsin plus lenalidomide is now used to move on to a frontline setting, and there is a multi-center study, phase 2, that using a chemotherapy-free combination for patients with PTCL. It would be interesting to see what is the clinical efficacy, as long as how long it would delay the need for chemotherapy in selected patient population. And the newer HDAC inhibitor, belinostat plus CHOP, is also being evaluated in combination to compare with the CHOP alone backbone. So I think, this is a very comprehensive list of what is being conducted with many of the clinical outcome still in the process. And with that in mind, it's important to look back into how much we have come along in terms of translational research and understanding the biological diversity and heterogeneity of T-cell lymphoma, and understand what are the biological drivers for subtypes of T-cell lymphoma. For example, the aberrant JAK-STAT pathway seems to be underlining genetic mutations for ALCL, ALK positive, and gamma delta type of T-cell lymphoma, such as hepatosplenic T-cell lymphoma and enteropathy-associated T-cell lymphoma type 2. So therefore, perhaps inhibitors targeting JAK-STAT pathway would have a clinical benefit treating patients with those subtypes, and genetic mutations that underlie recurrent epigenetic modifiers, such as the one that we see in follicular helper T cell, cell of origin subtypes, such as AITL or nodal follicular T cell, T helper cell subtypes. Perhaps those would be more sensitive to epigenetic modifier, HDAC inhibitor, or hypomethylating agents. And PTCL-NOS remains to be heterogeneous. However, different biological agents might be able to confer treatment sensitivity depending on the biological components. So in summary, T-cell lymphoma remains to be challenging, clinical challenge to manage, and CHOP is the most common treatment options in clinical practice settings. However, it is inadequate. Addition of etoposide and consideration of autologous stem cell transplant may improve efficacy, especially for physically fit patients, and development of novel agents alone or in combination with chemotherapy are promising, and in fact could deliver the promise of personalized therapy for patients with T-cell lymphoma. So we're really eagerly awaiting many clinical trials that are ongoing, and hopefully next year we would have more data to share in terms of what are the more promising novel treatment combinations for T-cell lymphoma. Thank you.